He's going to be talking about progress and controversies in multiple myeloma, and I'm so glad. One thing that Dr. Manni's excellent at a lot of things, but one thing that I especially appreciate about him is he's refreshingly authentic in his presentations. And this one is going to be about myeloma research and progress that has been accomplished, but it's not all butterflies and rainbows, and he will be explaining kind of both sides of the research. Because he wants the myeloma community informed on the full picture of what's happening. With that being said, sorry that I made that transition too early, Nico, but Nico will now be introducing Dr. Mohyuddin.
No, thank you, Audrey. So Dr. Mohyuddin, as the slide says, completed his medical training at the prestigious Aga Khan University in Pakistan. He completed his internal medicine residency at the University of Kansas, where he developed a passion for medical education and treating hematological malignancies. After residency, he pursued chief residency at the University of Kansas, focusing on mechanisms of novel educational delivery and improving access to research for trainees. He completed his fellowship at the University of Kansas, developing a clinical and research interest in multiple myeloma and drug repurposing, quality of scientific methods, end of life, cost-effective evidence-based care, and medical education. He enjoys the outdoors tremendously, so we're happy to have him here in Salt Lake. And that drew him to life in Utah, where he is currently an assistant professor at the Huntsman Cancer Institute with a focus on multiple myeloma. And thank you for being with us, Dr. Mohyuddin.
Well, thank you for having me here. The honor is mine. I'm just going to quickly share my screen here. There we go. Well, as you can see, my hair has grown quite a bit since that picture. I look like a completely different person, but it's still me. I'm really honored to be here today. And I think it's one of the most meaningful things that I feel like I participate in, being able to provide education directly to patients. So this means a lot to me that all of you are here, and I'm very eager to share some of my thoughts today. So let's get started. So I don't have any conflicts of interest to declare. So as we all know, I'm just going to start by saying that this talk is going to be a little different. All right, we have made tremendous progress in myeloma, but not all progress is created equally, and not all progress directly helps you for your specific situation. And I think we're going to sort of go over some of that. And I think that unfortunately, and myeloma is not the only field, but unfortunately, hype is a big problem in oncology. And I think that I kind of want to highlight those aspects as well. And I'm not by any means encouraging, conspiracy theories here. There is tremendous progress and the industry is doing absolutely amazing things. But I just kind of would hope that at the end of today's talk, you'll think a little differently about terms that you hear, about the news that you hear. I think it would give you some additional perspective and context. And I think that's very, very important for patients to be educated themselves, because sometimes you'll hear a lot of hype, and I kind of want to provide you with the defense and the resources to recognize what is real progress and what is not real progress. So this slide will indicate that there's been tremendous progress. Now, this slide doesn't even include the last 2 years, okay? So up until 2019, multiple drug approvals, multiple combinations approved for the treatment of multiple myeloma. And in the last 2 years alone, we've had 2 CAR-Ts, all right? We've had other new drugs approved. Melflufen, we'll talk about that, didn't really translate into anything necessarily meaningful for our patients, but we've had multiple triplets, multiple new drugs approved. So there has undeniably been progress in myeloma. But one of the key themes that I would hope that we all understand today is that the number of drugs approved isn't necessarily a surrogate for how good things are in a field, that sometimes new drugs being approved can be what's called lateral growth as opposed to growth forward. So you're getting more options, but not necessarily a step forward in terms of patients living longer or better. So yes, the number of drugs approved is important, but sometimes it's not a good surrogate for true progress. So I kind of want to highlight how, daratumumab has been a true game changer. It is a versatile drug, can be added to multiple combinations. In every single trial that it's been studied, that trial has been positive in every single trial. And, cilta-cel is a fairly new drug. And for those able to get it, it seems that cilta-cel is going to change the natural history of the disease, right? So you're talking about patients who've relapsed on multiple lines of therapy, where in the past, whatever you gave them would have like a 20-30% response rate, and that response would last 2 to 3 months. And now those patients are, almost everybody's responding, and they're responding for a period that's exceeding 2 years. So that's fantastic. And I think that this, when studied in randomized trials, and it is being studied, is going to be a game changer. I'm going to talk about some caveats about this analysis, but I want to recognize that these are true advances in the field. All right, but do all these approvals add incremental value? So we have daratumumab, undoubtedly a great drug. All right, then we have isatuximab, which is a very effective drug as well. But does it add to daratumumab in any meaningful way? And a hypothetical scenario is, if we were in a world where isatuximab did not exist, but daratumumab did, would any of your lives be any different? And I don't think so. I think that as long as you got access to daratumumab, the presence of isatuximab would mean nothing to you guys in terms of living longer or better. So the confirmatory trials for isatuximab, they didn't go against daratumumab. They designed trials that were easier for them to get drug approval. So they compared 3 drugs versus 2 drugs. So they compared against Pomdex, and in another trial, they compared against carfilzomib and Dex. And unfortunately, if your disease is refractory to daratumumab, there is a 0% response rate. You see the graph here on the right. Nobody responded. They either had stable disease or progressive disease. And I want to emphasize to you that this problem is not unique to myeloma. So in lung cancer, we've had multiple immunotherapy drugs. And the reason why I put this here is that in November 2016, the best journal we have, the New England Journal of Medicine, we find out that pembrolizumab is better than chemotherapy for a specific subtype of lung cancer. But hey, industry wants to cash in on this, right? So several months later, they start a new trial, and they're not comparing against pembrolizumab. They're comparing against chemo, even though we know that chemo is already worse than pembrolizumab. But a new trial is happening several months later, testing the same thing. And this happens time and time again. You see a positive result, industry wants to make money. In the process, they'll help people, I don't doubt that, but they want to make money. And they're going to design a trial that's going to make it easier to get regulatory approval. Do we already know if the control arm is inferior at the time of trial initiation? So as you all may know, starting a trial takes time. It takes years from when a trial is conceived to the time when a trial results. And it also takes a substantial amount of time to when the first patient is enrolled. But we studied this for myeloma. We published this in Lancet Hematology. We looked at trials enrolling in the US, all right? We're not even looking at trials outside the US. So these are trials that enroll in the US. They also enroll outside the US, but they at least enroll in some sites in the US. And we looked at trials that, all trials over the last, 10 years that enroll in the US. And we found out that amongst 49 of those trials, 9 of them, basically, let's start with first. So 7 of them enrolled onto control arms that were already known to be inferior. So before even the first patient enrolled, we knew from another study that that control arm was inferior to something else that was available, something else that was published, all right? So 14% of studies fall in that category, 18% of studies, an additional 18, you have trials that continue enrolling after you find out that that regimen, the control regimen, is inferior. And they enroll, sometimes it's the majority of the time that that trial is enrolling, they're enrolling onto an inferior control arm. And unfortunately, sometimes it's the same investigators. So the same investigators that are now running this new trial have previously ran the old trial that showed that that control arm was inferior. So that is a little sobering, right? It's a little, it's pretty depressing when you think about it. So I won't get into the technicalities, but we basically looked at, when a regimen was first shown to be inferior, and we looked at the time point, and then we compared to when a new trial started enrolling. And this is an example, right? Selinexor, bortezomib, dexamethasone. The trial began enrolling in April 2017, and we knew from December 2015 that, let alone a triplet, a 2-drug regimen was better than bortezomib and dexamethasone. So it's pretty unfortunate, right? Like, it's been more than 2 years, and you have a control arm that's really inferior, and this enrolls in the US. So you get lateral growth. When you get this regimen approved, you don't know whether it's better than all of the other existing options that you have. And if you look at the landscape of myeloma treatment, if you look at relapsed refractory disease, you have so many trials that compare 3 drugs to 2 drugs, and you don't know which 3-drug regimen is best. And this is a product of trials that are basically incentivized for regulatory approval. Those trials are designed to get the drug approved, not to advance standard of care. And sometimes the control arm of those trials is bad for patients. And industry can get away with it because, we're in a desperate situation, right? You go to some countries and they don't have other options. And if half the patients, in the control arm, in the intervention arm might get a good drug, these investigators are up against a wall. But industry can do better, right? We shouldn't be exploiting global disparities for our benefit. We still have trials open today that are enrolling on pomalidomide dexamethasone arms. And we know that POM-dex has been inferior for a long, long time. We've known since November 2018 that ELO POM-dex is better than POM-dex. And today you have a trial that still enrolls. So again, I've emphasized this, that these get drugs to market, but they harm the control arm. And I'm from Pakistan, and we are a former British colony, and there are a lot of parallels between colonialism and what happens today, where existing global disparities are exploited. You go to countries where the standard of care is different than the US. You go there, you run your trial, you get your benefit, and then you don't really serve the local population. You're running trials to get drugs in the US, because in the US you earn a lot of money for your drugs. So we studied this in myeloma, okay? This trial, this is not published yet. It's going to be out in JCO Global Oncology. And you can see the socioeconomic divide. The blue line, rich countries. In rich countries where trials are ran, the drugs get approved. The green line are poor countries. The drugs don't get approved. And the orange line is, somewhere in the middle, upper middle income, where sometimes it gets approved and sometimes it doesn't. So basically, you run trials in a whole bunch of different areas, and the richer countries get the drug later, but the poorer countries don't. So how did the poorer countries benefit, right? They didn't really benefit. You didn't really show commitment to helping them. And then the other tragic part. So I kind of want to explain this concept to you. I think even as healthcare professionals, we don't think about this a lot. But what is crossover, right? So I'm going to give you guys the example of daratumumab. Now, we know that daratumumab is a very effective drug, and it was known to be effective for relapsed refractory myeloma, right? That's where it was first studied, in the relapsed refractory setting. So now Janssen wants to move this drug to the newly diagnosed setting, right? So the onus is on Janssen to give daratumumab upon progression, right? If you're studying it in the newly diagnosed setting, right? And you're doing it again, data plus something versus just something, right? The arm that's not getting data should get data upon progression, because you already know that it's effective at relapse, right? So that's crossover, and crossover is needed when you're moving a drug that's already known to be effective to an earlier line of treatment, all right? So it's a very, very, very important and very poorly understood concept, even amongst healthcare providers. So we studied this, all right? And we found out that post-protocol therapy, or crossover, when it should happen, it doesn't happen. And it's not reported, right? So we never know what happens to these patients after the period ends. Do they get treatment later or not? And in a disease like myeloma, where you can live through several lines of treatment, it's important to know what's going on holistically, right? You're not in this isolated bubble. It's important to know what happens afterwards. And look here, so this is interesting, right? So in the trials where daratumumab was studied for relapse disease, okay, crossover happened, all right? In the trials where daratumumab was studied for newly diagnosed disease, where you should be giving daratumumab upon progression, it wasn't given. It was given to a very small number of patients. So in the Maya trial, which you hear a lot of hype about, which is a good regimen, in which the 3-drug regimen of Dara, Revlimid, Dex was compared to Revlimid, Dex, when the patients in the control arm of Revlimid, Dex progressed, none of the 3 most common regimens contained Dara, all right? In the Alcyone trial, which is less relevant to the US, but again, Dara, Velcade, melphalan, prednisone versus Velcade, melphalan, prednisone, only 10% of patients in the control arm received a Dara-containing regimen at first progression. You hear a lot about attrition and people don't make it to the next line of therapy, but this is not that. These are people who made it to another line of therapy, but they didn't get daratumumab. So now if you tell us that giving daratumumab makes people live longer, well, it's under a hypothetical situation where people are being deprived of daratumumab later, right? So, and that's not relevant to the US, right? Because in the US, if you don't get daratumumab at the time you're diagnosed, if you relapse, you will get daratumumab or isatuximab, something similar along those lines. So our field doesn't care about it, and nobody can answer why was more daratumumab given to the control arm in these relapse trials compared to the newly diagnosed trials. Nobody has an answer and nobody seems to care. And I got in trouble. So I asked this question for another, daratumumab trial. And I asked, why was daratumumab not given? And the answer was, well, the Candor study was initiated in 2017 across 19 countries, and access to subsequent daratumumab depended on regulatory approval in those regions. Well, in the US, from daratumumab was approved in November 2015. You started your trial in 2017. The excuse of regulatory approval is not good enough. And I showed to you here, I'm going to go back here. In those poor countries, if you don't apply for regulatory approval and you don't get it, you can't use that as an excuse, right? Like you don't seek regulatory approval and then you use that as an excuse to not give effective therapy, and you make enough money where you can do it. So Janssen made $6 billion a year from daratumumab. So they can afford to do better as far as the control arm is concerned and giving therapy is concerned. But I don't think it's a priority for us in the field. There are very few people who would, advocate for it like I am right now. It's just not a priority. So I got in trouble for this. I got blocked on Twitter by quite a few important, key opinion leaders just because I published this paper and I'd asked about it. So the other thing is what truly matters. So in my opinion, what truly matters is that my patients live longer and live better, all right? Better quality of life and longer life. Now, unfortunately, what happens is that sometimes a drug can make a tumor grow smaller on a scan, or it can make numbers look better, but that doesn't translate to people living longer. And this is a very important concept to grasp, that progression-free survival, which is what we refer to, right? Where how long a time passes, until your numbers start coming up, is not the same as overall survival. And there are important examples where a drug has improved progression-free survival but worsened survival. So ideally, you should be studying things that really matter. And I recognize that in newly diagnosed myeloma, where people live a really long time, overall survival may not be practical, but there are situations where it is practical, all right? So we studied this. And as you can see, that across 5 common blood cancers, So across 5 common blood cancers, the use of clinical outcomes, which is overall survival or quality of life, is a very small percent of trials. So less than 20% of trials truly test clinical outcomes. Ideally, you should randomize. And the point of today is not to have a deep discussion about why randomization is good, but ideally that's how you compare treatments, right? But where, as you see, amongst all heme malignancy trials, the proportion of trials that are randomized is dropping down, all right? We're getting more and more small studies that may not have the statistical power, or they may not be asking even the right questions that our field needs, right? Which approach is better? You're just getting a lot more non-randomized studies. So very concerning. And I studied this specifically for myeloma. And you can see here, the blue line, percent of trials with overall survival as an endpoint is in a free fall. It wasn't that much earlier, and now it's even less, all right? And percent of trials with response rate and progression-free survival has been going up. And you can argue that, OS is more difficult, but there are situations where OS is not difficult, where you can look at OS, and we still don't. So CAR T is great, right? We're all excited about it, but there's a big selection bias and there's a big waiting list. And I want you to sort of understand that the patients in the CAR T trials that we see, and when you hear that a product has a 99% response rate, you need to understand what the denominator is, all right? So in order to get CAR T, you have to have survived the waiting list. You have to have survived the waiting list for the clinical trial. Your disease has to be stable enough for 4 to 5 weeks for you to, so you don't die, you don't get an infection, or you don't progress for those 4 to 5 weeks, which is the amount of time it takes from when the cells are collected to when the cells are delivered, okay? So you're filtering out people with really aggressive disease. And I've had patients, I had a young lady who was 34 and she was never stable enough for CAR T. She died before she could get CAR T. So when you hear that cilta-cel has a response rate in everybody, it's important to look back that it was 113 patients who actually were enrolled on the trial, but 97 of them got the product. So the denominator that you hear is for this 97. When you hear it has 100% response rate or 99 or whatever, it's not the 113 denominator, okay? And we've studied this, all right? So that's what we call an intent to treat analysis, where the denominator should be all patients whom you intended to treat, because that's real life. Not everybody is able to follow the protocol. Some people die, some people progress, some people can't follow through. So as I joke about it, CAR T cells are immune to the intent to treat analysis. And the response rate, if you account for the denominator, is usually about 8 to 12% lower. MRD, there's a lot of excitement about it. And I am very excited about using MRD as a way to adapt treatment, all right? So individualized treatment. So people who are responding deeply, who acquire MRD negativity, maybe we should hold back and not do super aggressive treatment on them, right? That's really a good way to individualize therapy. But when you look back and you compare people who responded really deeply to people who didn't respond really deeply, what you're doing is you're establishing a prognostic marker, all right? So that's how we've looked at MRD, right? You've looked back at trials and you've compared people who responded really well. They all got, let's say you give 100 people VRD and 30 of them get MRD negativity and the 70 don't. And then you look back and you're like, those who acquired MRD negativity did better. Well, they all got the same treatment, right? And what you're basically assessing is their biology. Some people have a biology of their cancer that makes them more responsive to treatment, right? So MRD assesses biology. Yes, it also assesses the efficacy of treatment, but some people will become MRD negative with less treatment, all right? And the counterpart is not all MRD positivity is a bad thing either. There are many high-profile examples of people who've lived decades with persistent MRD positivity. So all of our landscape of MRD research basically is where you compare people who responded to those who didn't respond. That helps establish that's a prognostic marker, but it does not make it an appropriate surrogate for OS. That doesn't mean you can replace that as your goal of treatment. Now, it doesn't matter what I think, right? I'm inconsequential. There's already a trial now. I mean, that's compared isatuximab BRD to BRD, and it's shown that the MRD negativity is better for the isatuximab BRD arm. Does that mean people live longer? I don't know. Time will tell, right? So it may be that people will live longer, but we have to be responsible with what surrogacy is and what a prognostic marker is. This is a little technical, and I'm not going to get too deep into this, but all I'm saying is that we need a lot more research and a lot more time before we can truly know whether MRD is a surrogate for things that truly matter, like living longer. We already have some trials. I mean, when you look back, people did get more MRD negativity with more intensive treatment, but over a long period of time, they didn't live longer. All right, that's the IFM 2009 trial. So we have to be very humble and grounded about this. And if you look back, and this is a study that's going to be published hopefully soon, MRD actually, it's been studied in an exploratory fashion. It has not been the primary endpoint. It has rarely been studied in randomized trials. It's just been studied as an exploratory endpoint, and yet we make such tall conclusions about it. PFS also does not equate to OS. In the past, an industry-conducted study showed that there was an association between PFS to OS, but there have been some high-profile examples. All right, the study on the left was venetoclax, bortezomib, dexamethasone versus bortezomib, dexamethasone. You can see here, so this is the progression-free survival curve. The blue line does better. Venetoclax does better. This is the overall survival curve on the lower side, lower left side. The red line is now doing better. So placebo is living longer than venetoclax. So PFS is not concordant with OS. And you see similar for melflufen and Pomdex here.
Manni, Dr. Manni, can I interrupt you?
Sure.
Can you explain one more time, just for our newly diagnosed patients, what PFS and OS stands for, please?
Of course. And I apologize. So a progression-free survival in simple terms is the amount of time it takes from when you start a drug to either when your disease progresses or you die. So that is a progression-free survival. And overall survival basically means that that's the amount of time it takes from when you've enrolled onto a trial or when you've gotten a drug to death. All right. So progression doesn't count, but death counts in OS. So a PFS will basically, give you an idea about the efficacy of treatment, but it's like this one small part of your disease course, whereas an OS will also account for this treatment and what treatment you got afterwards. And sometimes a drug can produce a really good response, so it can keep your disease in control. But let's say overall, it also causes a lot more side effects, and people get infections, and people die more. So sometimes you can get a bit of a discordance between PFS and OS. And throughout oncology, there are a lot of examples of drugs that have shown a reduction in a protein, but that has not translated to people living longer. So that's something to be mindful of. And we've studied this, all right? And you can see here, I'm not going to get too technical, and this is going to hopefully be published in the next few months, that for myeloma, at least for newly diagnosed myeloma, the scatter plot is all over the place, and PFS is not really necessarily correlating neatly with OS. So I'm not saying that we need to make OS the endpoint for newly diagnosed myeloma. I recognize that it's impractical at times, but all I ask for is humility, and all I ask for is understanding that all of these terms, you hear these terms thrown around very loosely. This is benefiting our patients. There's a clinical benefit, but sometimes a PFS benefit does not mean you're going to live longer. And we don't even know that for MRD negativity yet. So all I ask for is a bit of humility and some introspection. And that's what I spend a lot of time thinking and researching. So I showed you an example of a drug that improved PFS, but not OS. How does media and our own patient advocacy organizations report such a finding? So look at this. So if you look at the left side of the screen, this is for a drug that killed more people. It might have had a better PFS, but it killed more people. And what does the report say? Melflufen dex better for myeloma patients without a recent transplant compared to Pomdex. So you're looking at a small subgroup, and you aim. What you do is you highlight that rather than highlight that overall what the study was powered to do. It killed more people. You look, and this is a patient advocacy website. If you look at the right side, that's a oncology news website, and it says melflufen dex demonstrates superiority. So our perceptions of what superiority is are so biased that even when we know that OS is worse, if there's a PFS benefit, in our mind, we're like hard-tuned that this is superior, this is a benefit. So we studied this, and we published this in Lancet Hematology. I teamed up, and it was an idea that came from a spouse of a patient with myeloma. This is her project. She was so bothered by the reporting of melflufen that she and I teamed up. We published this in Lancet Hematology. We looked at all news reporting of this trial, and in the 16 articles, about 9 of them were positive, 5 of them were neutral, and 2 of them were negative. One of the negative ones I wrote. So I don't know if that even counts, but very, very sobering, right? Like we're just so into this PFS business that even when a drug kills more people, we just will write that is better because we're just so into this PFS business. So I think that, I covered a lot of themes today, and I want to emphasize that progress is tremendous. Patients with myeloma today are living a lot longer, but we shouldn't hurt patients. We shouldn't exploit those patients in those control arms, and we shouldn't exploit global disparities, right? And those patients who put their trust in us, they deserve good therapy upon progression, and the sponsor can afford to give it. And our trainees don't think about this, right? We live in an environment of hype where I am the minority view, right? Like I spend a lot of time thinking about this, but other people don't. And I think that hopefully we're seeing some change, but our trainees need to think about this and not buy into hype. Exciting technology like MRD has to translate into living better and longer. And this kind of research, it doesn't get you money, it doesn't get you those big grants, but it's important. And again, I want to highlight this, and maybe there's hope. And I don't want to be presumptuous that it was me or my colleagues who led to this happening. But we put a lot of pressure on a pharmaceutical company when they had ran a trial with a bad control arm, and basically they changed their control arm. So at a conference in December 2020, they tell us that they're going to compare selinexor Pomdex to Pomdex. And then over the next few months, there's a lot of pressure, there's a lot of advocacy, there are multiple papers that are published. And then lo and behold, in spring 2021, they tell us that the triplet arm has been, the control arm has been changed to a triplet. And maybe there's no cause and effect here, but I'd like to think that our advocacy played a part in this, right? That we put pressure on them, we raised awareness. And I think there's hope. I think a lot of the newer generation of trials have good triplet control arms, and I think that we are seeing some positive positive influence. And every day I get trainees that reach out to me, and they're like, we like the way you're highlighting these issues, and it's very inspiring, and we also want to think about these things and not buy into hype. And I think that there's hope and there's tremendous progress, and it's undoubtedly true that the landscape of myeloma treatment has improved, but we can do better. We have a wealth of options, but because industry is not incentivized to compare those good options to each other, we don't really know how to best sequence our therapies and how to best use all of the luxury of options that we have. So I thank you all for listening, and I've left about 25 minutes for us to go over some of these questions.
Thank you so much, Dr. Manni. Seriously, I hope you guys understand what I mean now by refreshingly authentic. He says things that I think maybe others might be too timid to say, so thank you. As we get started, one of the questions that I've had recently, and I'd love to get your take on this, one of the most important things is quality of life of myeloma patients, but how can we accurately clinically test that, considering it's so subjective? What's your opinion on this?
That's a great question. So there are validated tools that we use to assess quality of life that have been thoroughly studied, and generally speaking, they are conducted in clinical trials. The problem is that how they're reported and how they're analyzed, there's a lot of spin to it. There have been multiple papers that have been published that highlight how industry arbitrarily draws a line that is of no clinical significance. So they arbitrarily mold their results in such a way that even if the drug wasn't actually meaningfully improving quality of life, they're going to show that it did. So there's a lot of spin that goes on to how quality of life is reported. And the other thing is that quality of life is rarely a main priority, right? So it's not the main endpoint that's being studied. And we've looked into this, and quality of life was a primary endpoint for I think 2 or 3 myeloma randomized trials amongst 150 that we looked at. So it's not a main endpoint, and it's very subjective in the sense that even though you have validated instruments, you can draw different lines in the sand and come up with positive results. And it's only followed for a small amount of time, whereas what truly matters is long-term,
Right.
robust measurement of quality of life. So there's a lot of technicalities here and a lot of ways where it's not reported accurately.
Interesting. Yeah. Long way to go then. Cindy was wondering, and this question was echoed by somebody else in the chat, for post stem cell maintenance in general, do you recommend adding DARA to a Revlimid regimen, or what is your consideration on that?
That's a great question. So outside of a clinical trial, I think Revlimid is the way to go, at least in one clinical trial from Europe, where patients received a daratumumab containing regimen as part of their induction. There was no additional benefit with continuing daratumumab as far as progression-free survival is concerned. So outside of a clinical trial, I would not add data to Revlimid, and especially if you received it during your induction. So we have trials that are aiming to answer that question, but as of right now, Revlimid remains the standard of care.
Awesome, thank you. Jesse's wondering, how are non-randomized studies even approved? Isn't randomization a key component of research?
That's such a great question. So, the reality is that the vast majority of studies are not randomized. And there's some good reasons for that, right? So let's say you have a new drug that has shown some efficacy in the lab and you want to study it. So the first thing you want to do is you want to show that it's safe, right? And you don't need a big randomized trial to get a preliminary idea of whether it's safe or not. You're going to give it to like 10, 15 patients and make sure that they handle your dose and maybe get a small idea of the efficacy. So a lot of phase 1 trials are phase 1 trials because they need to be phase 1 trials, right? That's a good thing. But I think one of the problems we're seeing, and it's multifactorial, is there's a lot of incentive for investigators and industry to run trials, right? So we end up getting a lot of duplicative trials. And in myeloma, you have so many drugs that you can come up with a novel permutation of 3 or 4 drugs, and you can come up with like so many permutations of 3 active drugs. So there's a lot of incentive to get, study a new permutation. And sometimes that new permutation may add to our knowledge, but sometimes it doesn't. So there's a lot of, and another incentive is recently the FDA has granted approval based on non-randomized data, right? So that's another incentive to run more non-randomized studies. So by no means am I saying that non-randomized studies are bad. They're important, they're pivotal, and you don't want to waste resources in a randomized study for something that won't even look good in a non-randomized study. But I think that it's a complex phenomena, and we definitely are seeing more non-randomized studies than we should.
Thank you. Thank you for sharing that. Question I had was, well, why do you talked a lot about, I'll call it the dark side of research today. What hope do you have in the myeloma field, and what makes you excited about the future?
That's such a great question. So we're truly blessed that we have so many like exciting treatment options that are coming, right? And it's not because other diseases don't try, right? Like I think about pancreatic cancer, where people have tried so hard, so much money has been spent, and we haven't been able to come up with good options. In myeloma, we've been fortunate enough that, every few years we come up with a new class of drugs that very obviously works, right? So CAR T very obviously works. Bispecific antibodies very obviously are working, these BiTEs, right? And I think that we as a field are beholden to industry, right? Like we're very thankful to them for the progress. And unfortunately, there's been very little pushback against them. I mean, they've given us a lot, but we haven't pushed back and asked for better. And I think that the next generation of oncologists hopefully will push back a little bit more. I think that the solutions to this problem have to come up from people higher than me, in the sense that, as long as the vast majority of trials are ran by, funded by, and designed by pharma, we're going to keep running into these problems, because pharma is not a charity, right? Like, I mean, they want to help us, but
Definitely not.
they want to help us, but they want to make money. And, sometimes they both align and sometimes they don't align. So I think that the government definitely needs to increase spending on clinical trials. So a lot of the money that goes for research, it goes for preclinical studies, discovering new compounds, but the amount of resources and money spent on clinical trials, on utilizing drugs that are already there and how to best use them, like we have very limited funding for that. The other thing is that the FDA needs to be stricter. The FDA needs to clamp down on bad control arms and update its definition of what an acceptable regulatory control arm is. So I see hope, and perhaps we're already beginning to see some changes, but I think that the system-wide change has to be more than just one person complaining about it.
Yeah, thank you for those insights. Nico is going to help me moderate this as
Yeah.
well.
So Veronica asked a question about what kind of faith we can put in our huntsman providers like yourself to kind of sort through these situations, catch these situations where we might, is there an arm of this study that is actually not going to offer patients less than the most effective standard of care?
That's a great question. So I reassure you that at Huntsman, the randomized control trial we have decent control arms. Else, we'd put our foot down and we'd not let them open. So the problem, I think that for the most part, patients in the United States, the control arms that they get are good. There are some examples. So it's a tricky situation, right? So the company wants to get their drug approved with the easiest way possible, right? So the bulk of their patients that they enroll are not in the US because they know that a bad control arm would not be palatable in the United States. But what happens is that they do have to enroll a very small number of patients in the US to make it like acceptable for the FDA. So if you ever look at these bad trials, I use the word bad here, but if you look at these trials, like there are a small number of centers in the US that enroll, and that has to happen. But the vast majority of patients enroll are from outside the US, where existing global disparities are exploited. That's my opinion. I think of this as modern day colonialism, but existing global disparities are exploited. But for the most part, patients in the US, I'd say that they do get decent control arms. There are some notable exceptions, but for the most part, they get decent control arms.
There was another question about 3 drugs and whether the push for 3-drug regimen had a profit motive behind it.
So that's a great question. So there's always a profit motive, and that's something to add that adds context to our discussions. But I will say that the cumulative evidence that we have when we compare 3 drugs to 2 drugs is enough where even somebody who has no financial conflicts like me, acknowledges that 3 drugs is the standard of care for myeloma compared to 2 drugs. Now, when you come to the 4 versus 3 debate, right, for newly diagnosed myeloma, there's a lot of things to consider. And it doesn't add a lot of toxicity. It does deepen responses. We don't know whether it will improve survival, but we won't know that for a while. I think on a case-by-case basis, after having that in-depth discussion, I think considering 4 drugs is appropriate, but you have to be real with your patients, right? You shouldn't upsell that this is going to make you live longer because we don't know that. And it does increase MRD negativity, but we don't know that either. But if the question is 3 versus 2, I think we have enough cumulative evidence from the multitude of 3 versus 2 trials that have been ran that 3 is better than 2. We don't know which 3 is better because pharma has never been incentivized to run a 3 versus 3 trial in the relapsed refractory space.
Somebody else asked about the smoldering myeloma. Is some of this kind of critical analysis applicable to the smoldering myeloma research?
That's a great question. So I've actually written some papers about it. So how I gave you an example earlier about redundancy in research, where you have a whole bunch of different permutations that you can study, right? Because we have so many active drugs in myeloma, you can come up with any 3-drug regimen and study it. We see that phenomena in smoldering. So you have a bunch of studies that assess different concoctions of 3 drugs. And all of these are small studies of 20, 30 patients. And none of them are powered for whether this is going to make you live longer or not. Their statistical power is for response rate or MRD negativity or progression-free survival. So I am of the opinion, and I've written 2 papers about this, that these trials do not advance our field forward. That if you have a multitude of small trials, they don't answer the question, should we treat these patients or not, right? You're not going to get to know that from a 20, 30 patient study in which you look at MRD negativity. So that is my endpoint. And I don't think that a data Revlimid Dex study is going to answer anything different than isatuximab Revlimid Dex, my 2 cents, right? Like they're fairly similar drugs, and I don't think that you need both studies. So that's my opinion. I see that, for high risk smoldering myeloma, like, would you recommend your patient a trial? It's a very, very complicated question. And I think that I could talk an hour about smoldering myeloma alone. And I think it's a very in-depth conversation that you need to have with your physician about whether treatment is right for you or not. Do we know if treatment will make us live longer or live better? I generally do not treat smoldering myeloma outside of a well-designed, good clinical trial. And there's one clinical trial that we have open at Huntsman that is actually powered for overall survival. So it will assess whether our intervention is making people live longer or not. That's a good trial. But generally speaking, I do not treat smoldering myeloma outside of a clinical trial. I recognize that there are situations where it's reasonable. I recognize that some people smarter and more experienced than me treat it. So it's a very controversial question. I think we'd need a full hour to talk about.
Well, I'll have to have you back in our smoldering chapter to come and speak on your opinion there. We do have an MGUS smoldering chapter. For those that didn't know, I'll include that link in our follow-up email. And I was going to mention as well, Dr. Manni has had an excellent presentation both on MRD, using that as an endpoint in clinical trials, and then also as well the role of maintenance therapy. So I'll be including, if you liked his talk today, I'll be including his 2 other talks in our follow-up email, because he's fun to listen to and has great opinions. Nico, back to you.
A couple of questions having to do with bispecifics. Somebody asked what's the best bispecific study. Somebody else asked, would you recommend one of your patients a trial for high-risk smoldering myeloma using a bispecific with DARA if it were available?
So the first part is we don't know which is the best bispecific study. All right. Anybody who tells you otherwise, like, we don't know. Like, you can do heterogeneous comparisons of different studies that have enrolled different patients, and you observe different response rates. But currently, bispecifics are only approved are only available as part of a clinical trial. So if you're at an institution that offers a bispecific and you meet the criteria for bispecific therapy, which means, you have relapsed refractory myeloma that's progressed on numerous lines of therapy, I would recommend that you enroll on that trial and get whatever bispecific is being offered. There are quite a few promising bispecifics. So like teclistamab, which is made by Janssen, is very promising. Elrantamab, which is made by Pfizer, is very promising. And there are a few others as well. But whatever one's available for you, I would recommend that you go ahead and get it if you qualify. Now, as far as the high-risk smoldering is concerned, it's problematic, right? Like, if the trial that you're being offered is a 30-patient trial or 20-patient trial and has an endpoint of MRD negativity, right? Like, I don't know how that will help the field. And if you are of the mindset that you want to be treated anyways, then you can argue that, right, if you were going to get treated anyways, you're getting some sort of treatment. But it doesn't answer the question, does treatment make me live longer or better? I have a condition that hasn't yet affected my organs, and it may never. Even high-risk smoldering myeloma, even the highest model, like, there's a percentage of patients who never progress and never need treatment. So you may potentially be getting treated for something that's never going to progress, right? So MRD, in my opinion, is a very flawed endpoint for that kind of a situation, right? As somebody joked, like, MRD has disease at the end, right? And you can argue that smoldering myeloma, it's asymptomatic, right? Like, it's not even a disease yet, some people would argue. So, like, what are you doing by eradicating a disease that isn't a disease that's bothering you yet? So Would I personally enroll in that trial? No. But I think that for your values and your preferences, it might be it might be the right idea for you.
Awesome.
And could you define bispecific?
So bispecific, or we sometimes refer to them as bispecific T cell engager or a BiTE. So this is an antibody that has two arms, and one arm connects to the T cells, which are the immune cells, and the other arm connects to a receptor on the myeloma cells, most commonly BCMA. So what happens is that what it does is that it brings the T cells, the immune cells, to the myeloma cells. So bispecific T cell engager. So it's engaging the T cells to a target on the myeloma cells. So we refer to them as BiTEs or bispecifics. It's the new class of drugs. We don't have an FDA approval yet, but we hopefully will later this year. And I think it is going to change myeloma treatment, and it's going to be probably more accessible than CAR T, because CAR T takes a few weeks, right? Like there are lots of hurdles to overcome, but this is available just like Velcade would be, right? It's like a shot. So long term, I think that it'll be very practical, it'll be effective, and it's going to change the field. And I say that, knowing that there's a lot of hype, but I say that with confidence that I think this truly is a good step forward.
Another question about the evolution of myeloma and whether, well, I'll read the question. MM is subject to, quote, Darwinian evolution as much as any other expression of life. Does this imply that MM is not only getting even more better in evading attacks by our medication, but also ever more aggressive through time? Are we building superbugs?
That's such a great question. And I think there's so many aspects to this, right? When you think from a clinical standpoint, I think that cumulatively these new options that we have are helping patients, and people are living longer. All right. I would argue to you that yes, the few cells that survive in those heavily pretreated patients, yes, they are subject to Darwinian evolution, and yeah, they are more aggressive. And this is a case that industry makes, and there's financial incentives as well. But the case that industry makes is give a lot of really good effective treatment up front to prevent these clones from even starting, right? Like when you think of tuberculosis medications, right? The reason why we do 3-4 drug regimens for TB is if you give just 1 or 2 drugs, resistant bugs evolve, right? So maybe it's a similar concept in myeloma, that you give highly effective treatment up front, 4 drugs, maybe 5 drugs in the future, and you prevent this from happening. So I don't discredit that. I think that it does happen. It varies from a patient to patient level, how much Darwinian evolution is going on. But more options and more lines of therapy generally do translate to better survival. And there is no best bispecific. So whatever trials available, we have no comparison. Because I see a question here. I just wanted to make sure I answered that. There is no best bispecific that we know of yet.
Awesome. Okay. And I got some questions about, is the MGUS smoldering chapter active? It is active. We just meet every other month. So that's probably why you might not see something up there right now. But we do have a doctor from Florida coming to speak to us on promising clinical, well, now I don't even know what's a promising clinical trial anymore, Dr. Manni. No, I'm just kidding. But I'm promising clinical trials that are for the smoldering myeloma, what's being told to us. And that's been done at, what is it? And what's the one in Maryland? NIH? NIH? Yeah, that one. Okay. A couple more questions, if you don't mind, and then we'll finish up. So Jesse asked a good question. As patients consider trials, are there key questions that you would ask the study doctor or the staff so that they can know whether what they're entering is worth their time and testing the right things?
That is such a great question. And so there are a few things to consider, right? So I think one of the important things that to ask your doctor is, what is the main question that this trial is answering? And that usually means, like in technical language, the primary endpoint, right? And I think that's very important to know, because the intention of a study may not be super clear to you as a patient. So you have the right to ask your physician, like, what is the endpoint? And then you should ask that, what is the expected benefit for me? And I think, because, like, you want to contribute, you want to be a global citizen, and you want to contribute to science, but we need to be very clear about what benefits and harms are there for you. So ask them, like, how am I going to benefit about this? And then if it's a randomized trial, what I think you should ask your physician, like, point blank, like, look them in the eye and ask them that, is this a control arm that you would feel comfortable, like, putting your mother or father on? And is this a control arm that you would consider putting me on if I was not going on that trial? And sometimes you'd be surprised if they answer this question honestly. So that if you're entering a randomized trial, like, ask them that, if I get randomized to the control arm, would you be comfortable, with me being on that? Would you have considered that for me outside of a trial? And if they would not consider that for you outside of a trial, I think it's time for you to just take a step back and think about it deeply, because maybe being on the control arm of that trial is not a good option for you. So though I think, and I can talk about this, like, again, this is another like an hour-long conversation about, what a patient should look for. But generally speaking, what benefit there is for you, questions about the control arm, and questions about what the study's main purpose or endpoint is.
Yeah, wonderful. Okay, and then another last question, just considering CAR-T, since we touched on that briefly today. This patient is wondering, and this again is a longer answer, so maybe just it's a loaded question, but should one have a CAR-T as soon as they're available, or should they wait until, like, as soon as they qualify for one, or should they wait to have it kind of in their backup regimen of, okay, if my disease starts to get worse, I have the CAR-T ready as my backup? Does that make sense?
Yeah, it's such a great question. And to be honest, we don't have high quality data that compares these two approaches. We do generally know that the more disease burden you have, the more the side effects are going to happen with the CAR-T. And the less disease burden you have, the more likely you are to have a more durable response to CAR-T. So and there's a lot of caveats, right? Because it's not easy to get a spot nowadays with all the waiting lists. But if you can get CAR-T and you meet criteria, and if I were in your place, I would probably want it sooner rather than later for these reasons. But I admit that we don't have high quality data to guide us in this situation.
Awesome, thank you. Nico, is there anything you wanted to add before we leave today?
Yeah, and thank you very much, Dr. Mohyuddin. In the question before last, you did propose 3 different sort of questions to make sure you ask your provider when being presented with the option of a trial. Is there anything else? So for patients, say at Huntsman, or for patients who are seeing this, other than asking those questions about about what's the endpoint, the main question, would you put your mother on this trial if it was on the control arm of this trial? Is there anything else you could say to offer reassurance to patients who?
That's such a great question. So one of the things that you should ask your physician outside of a trial as well, right? Is this treatment expected to make me live longer or better? And if your physician is honest with you, sometimes a lot of the treatments we offer, we don't know the answer to that question. So that's something you absolutely should ask, because, and I don't want to speak on your behalf, but for a lot of us, our priority is to live longer and live better, right? It's not just to bring the numbers down, but also to live a longer and a life with better quality. So ask that. So that's something I would unequivocally recommend. Ask your physician, like, is this approach going to make me live longer or better? And sometimes the physician, if they're honest with themselves, the provider, they'll tell you that we don't know, but I hope that that's the case. And that's what I say with my patients when I talk about quad therapy, right? 4 drugs at newly diagnosed disease. I see that some of my patients are on here, and I've had that conversation with them. So those are, I think that's the one important thing, like what you should do, what your physician is doing for you should translate, or at least the physician should hope that it would translate into you living longer or better. So, yeah.
So, and there seems to be two types, and I'm sorry, I just had one last question. There seems to be a couple of different ways in which a drug or a trial could fail to really deliver for a patient. One would be to just be kind of incrementally not accomplish very much and sort of be a waste of resources and of time and in theory, at least, the FDA won't approve a drug that doesn't hurt somebody but also doesn't help them. But something that you introduced a little bit in your talk was the possibility that by sort of sending people into control arms that are worse than standard of care that's available to them otherwise, that they might end up in a worse off by entering the trial than they would by, if they had the sense to not enter that trial. Is there something that how do our people watching this know that they can avoid that fate?
You bring so many great points, and some of your points aren't even questions. They're like very valid, legitimate points in themselves that I don't have a whole lot to add to. I think that, at the time, so sometimes we don't know, and a very well-designed trial can go really wrong, right? Like you never have anticipated that more people would die with a certain therapy, and people die. And I mean, nobody intentionally did that. So some things are unavoidable, and these are risks that unfortunately, patients take. But I think the control arm business, like there are trials where the control arm is known to be inferior. And I think that we can avoid that by proactively asking questions as patients. Physicians can contribute to this by refusing to open trials at their institutions that have bad control arms. And we've publicly spoken about a few trials, and and I've said that I'm not going to let this open because it's like, I wouldn't do this for my patient outside of a trial. And the FDA ultimately can enact the greatest change by mandating better control arms and by tightening up some of the regulatory standards. You brought a point that you said that, you would hope that if the drug is approved, it's making people live longer. And sadly, there are many instances, and perhaps more so in other cancers, where drugs have been approved where we don't know whether they live longer or not. Like in pancreatic cancer, there's a drug that's approved that shrinks the cancer for 2 weeks longer than if they didn't get the drug, and it didn't necessarily make people live longer. So that's pretty tragic, right? But it's approved. I read a news article today, and again, this speaks to hype, right? So the title was, "This drug improves progression-free survival for sarcoma." All right. And the primary investigator was like, "This drug led to a 30% improvement in progression survival." So what was the improvement? It was 2.8 months versus 2.1 months, 3 weeks. And we can spin these things. We can frame it in relative percentages, and we can play these games, and our new media will hype it up. The title never said anything about it, right? You can do a quick read and never even grasp that you're talking about a 3-week benefit. But that's the infrastructure that we're in. There's so much hype that it's hard to differentiate. So I'm just giving that example because I think that sometimes our regulatory approvals and what we celebrate in our field is I don't even know how to frame it. It's pretty tragic.
Well, Dr. Manni, it's interesting because it's not only in the medical field that this is happening, it's everywhere. So I think this is a great reminder that as people, we have to be aware of what we're consuming in the media and aware of what's going on, and that we're not just taking things at face value, but that we care about ourselves enough that we're being, what's the word? investigative with what we're learning, and that we're verifying the truth of everywhere, whether it's in school, whether it's in medical field, anyway, I just think that this is a good reminder for us as in this technological age of media consumption to be aware of what we're both publishing and reading. So thank you for that reminder. Awesome. Nico, anything else?
Oh, thank you very much, Dr. Mohyuddin. This was very,
that was
very
amazing.
engaging.
That was amazing. Super great. I'm just going to close with a couple of outro announcements and then we can be done here. But thank you so much, Dr. Manni, for your time today. And thank you, Nico, for your help as always in co-chairing this chapter with me. Next month, we're going to hear from the Diversity, Equity, and Inclusion Program Manager for Huntsman, Kadi Youd. And as well, we're going to hear from the African American Myeloma Initiative Director, Marcia Calloway Campbell. They're going to explain the importance for this program and volunteer opportunities to us to help spread myeloma awareness and education in underserved communities and populations within the Mountain West region. That event will be June 15th at 1 p.m. Mountain. You may be interested in other myeloma crowd community events we have coming up. The 24th is our immunotherapy treatment chapter. This is going to be learning about antibody drug conjugates with Dr. Jesus Verdeja. On the 25th is the relapsed refractory myeloma treatment chapter. That recently changed. So instead of 1 p.m. Eastern, it's going to be at 12 p.m. Eastern, just a slight change due to an unexpected conflict. But we're going to be talking about infection prevention for multiple myeloma patients with Dr. Benjamin Durman. Then on the 26th, we'll have our African American Myeloma Community Chapter. And we'll be hearing from Will Wright, who went through a very well-designed clinical trial and was able to greatly improve his quality of life. We're going to be talking about changing your diet while keeping your culture, and how as a MGUS patient, he was able to completely change his life around and lower the risk potentially of his myeloma progression. So that's going to be an exciting meeting. The link to sign up for any of those events and even more events I didn't mention is found at the bottom of the slide and will be found in our follow-up email along with those resources that I've mentioned throughout. And as always, I'd like to thank our sponsors again, Bristol Myers Squibb, GSK, Genentech, Janssen Oncology, and AbbVie. And a big thank you to each of you for helping us build this Mountain West myeloma community. I appreciate you. And thanks again, Nico, for your help. Thanks again, Dr. Manni, and hope that you guys have an excellent rest of your day. Thank you, everyone. Take care.
Thank you.